Good afternoon, everyone. So, this is Sazedur Rahman Akanda, Assistant Professor, School of Pharmaceutical Science, Department of Pharmacology. Today, I am going to present about antihypertensive drug. So, today's contents is introductions, type of hypertension, risk factor, classification of antihypertensive drug, pharmacology of antihypertensive drug, and then references. So, here it is the introductions. Before telling about antihypertensive drugs, so let us understand about hypertension. So before hypertension, let us understand about blood pressure. What is blood pressure? Blood pressure is nothing but the pressure which exerts on the wall of blood vessel. It's called blood pressures. Okay, so that means the pressure which is exerting on the wall of blood vessel, it is called blood pressures. So now let comes to hypertension. So what is hypertension? Hypertension is nothing but is an elevation of systolic and diastolic BP above 140 by 90 mmHg. So what is this? So actually the hypertension is nothing but, as we know, the normal blood pressure is 120 by 80. So 120 is the systolic pressure and 80 is the diastolic pressure. So when the persons or any kind of patients are getting more BP, so it is above 140 and above 90, so that comes under hypertension. Okay, so also you can say about hypertension, the heart is working harder than normal, putting extra strain on the heart and blood vessel. Why? Because heart is getting more and more pressure, na? So because of this blood vessel constrictions, right? So that's what the blood pressure will be elevated, and it will be more than 120 in systolic and more than 80 in diastolic. So that comes under the hypertension part. Okay, so again, if you're telling about systolic blood pressure and diastolic blood pressure, so as we know, there's a two type of pressure we can count. Okay, one is systolic blood pressure, one is diastolic blood pressure. So what is systolic blood pressure? It's nothing but the amount of pressure against the artery walls is time the heart contract. Okay, so diastolic blood pressure, the amount of pressure inside the artery when heart is at rest positions in between the heartbeats. So again, yeah, if we tell about that, the blood pressure is determined by the cardiac output. So how much amount of blood just goes out from the heart. Okay, so and if this prolonged hypertension is there, if any persons are suffering from prolonged time of hypertension, so there will be a problem of the heart, there will be a problem of the brain and kidneys, and there may be severe complications will occur like stroke, coronary artery disease, or renal failure. Why? Because the blood vessel will be getting constricted. So sometime pressure will be more exerted, right? So in this condition, this kind of heart cell, brain cell, and kidney cell may be damaged. Now we can discuss about types of hypertension. So what are the types of hypertension? If we say about types of hypertension, there will be two types of hypertension. One is primary hypertension, then secondary hypertension. What is primary hypertension? In this primary hypertension is not a clinical hypertension. What is the meaning of clinical and non-clinical? Clinical in the sense the patients, whoever is suffering from the hypertension, that is totally comes under a clinical part. That means it is considering as a patient. And non-clinical means which is not considering as a patient. So in this we can tell about the primary and secondary hypertension, that the primary, where the causes are not known, the patient may be suffering from hypertension. Just giving one example, suppose because of any kind of sudden trauma or any kind of tension, anything happened to anyone's life, or anything happens, okay, because of that maybe sometime pressure may be elevated. Suppose if I'm running from here to Guwahati somewhere else for 5 or 6 kilometers, so in that time there will be a sympathetic nervous system stimulations will be there, and because of that my BP may be raised, and if whenever I take a rest, so automatically that BP will come down to the normal. So that is a time bound, and because of certain things what we have done, because of some activities, this hypertension may be increased, the pressure may be increased, and that can be considered as an primary hypertension. So what is secondary hypertension? Secondary hypertension, it is a totally clinical part. So there may be a problem of the heart, there may be a problem of the kidney. So if there's a problem of the kidney, so ultimately there will be no enough amount of sodium or potassium cannot be excreted out from the body, and there may be a retention of more water, there will be retention of more plasma volume. So this kind of reasons, whenever the patient are suffering from hypertension, so that will be called as secondary hypertension, as well as this can be comes under the clinical part of hypertension. Next, so risk factors. So risk factors for the hypertension patients, so who can be is suffered from the hypertension, that comes under risk factors. So if the patient are above 65 years of age, so that kind of people are in the risk factor of the hypertension. So family history, suppose my parents are already suffering from hypertension, so there will be chances of coming to me as a genetic wise this hypertension. So that one kind of family history, if it is there, so hypertension may be getting the chances of getting hypertension is more. So now again, tobacco, if you are consuming tobacco, smoking, so there will be a chances of getting hypertension. Next is a diet, high salt and oil intake and alcohol, and during the time of stress condition, if you are taking so much of stress, so that also a main reason of getting hypertension. If you are taking so much of salt, because it is a sodium and chlorine, so if it is retained in our body and if you are consuming more, so there will be a chances of getting more kind of extra load to the heart, and there may be more chances of getting extra load to the kidney. So there may be a chance of getting hypertension in this case also. So classification of antihypertensive drugs, there will be so many classification of antihypertensive drugs. Let me explain about one by one. Diuretics, so under that thiazide diuretics, so under that example is hydrochlorothiazide, chlorothalidone, then indapamide, then under loop diuretic there is a furosemide, bumetanide, then torsemide. So these furosemide are widely used as diuretics, those are suffering from hypertension. And then potassium aspirin diuretics, there will be spironolactones are widely used in the market. Then AC inhibitors, captopril, then ramipril, enalapril, the angiotensin blockers, losartan, valsartan, candesartan, renin inhibitors, aliskiren, ramikiren, then beta-adrenergic blockers, non-selective beta-adrenergic blockers, under that propranolol, metoprolol, timolol, selective beta-adrenergic blockers, bisoprolol, metoprolol, atenolol. Then beta-adrenergic blockers, selective alpha-adrenergic blockers, that is a parazosine, terazosin, doxazosine. Then non-selective alpha-adrenergic blockers, phentolamine, phenoxybenzamine. Then alpha-beta-adrenergic blockers, labetalol, carvedilol, calcium channel blockers, L-type of calcium channel blockers, this is verapamil, diltiazem, then dihydropyridine, nifedipine, nicardipine. Then potassium channel openers, minoxidil, diazoxide. So this minoxidil is widely used in the market. Vasodilators, minoxidil, hydralazine, then arteriolar vanodilator, so sodium nitropyroxides, then centrally acting sympatholytics, cholinidine, alpha-methyl dopa. So these all are the drugs comes under the hypertension. So now if you are telling about one by one how these kind of drugs are working to our body. So these diuretics, how it is working to our body, if we tell about that, diuretics enhances the excretion of sodium and water. What is that? So excretions of sodium and water. So as we know, if there is a more amount of blood, if there is a more amount of blood plasma volume will be present in our body, so ultimately it will be occurring the pressure at the wall of the blood vessels. So ultimately that has to be reduced down while giving the treatment, right? So these diuretics will be excretion of sodium and water, so by that the plasma volume will be goes down, as well as sodium will be goes down, as well as the extra pressures on the wall of blood vessel will be goes down. So by that the hypertension, the patient who is suffering from hypertension, it will be coming to the normal BP. So now again we can say about hypertension, increased sodium chloride excretions, as I already been said. Then plasma volume, decrease the plasma volume, then decrease the cardiac output. Once the cardiac output will be decreased, that means the load in heart will be decreases. So ultimately output also will be decreases. Ultimately BP also will be going to be decreases. So now if I tell you about the thiazide diuretics pharmacokinetic actions, so what is the pharmacokinetic actions for the thiazide diuretic drugs? So extensively protein bound, all are excreted in the urine mainly by tubular secretions, and their action starts within 1 hour, but the duration varies from 8 to 12 hours. Now if I tell about the ADR, so there may be some kind of ADR. What is the meaning of ADR? The adverse drug reactions or some kind of side effects after taking the thiazide diuretics. So it may be hypokalemia, that means the potassium level maybe goes down. Hyperuricemia, maybe increasing of uric acid level. Maybe hyperglycemia, maybe increasing of glucose level. Hypercalcemia, maybe increasing of calcium level because of taking of this kind of drugs. So now we are telling about thiazide diuretics, CSF, congestive heart failure, hypertension, edema. Why these thiazide diuretics also been used in congestive heart failure? Because this antihypertensive drugs, whenever we are giving, so it will be relaxing the blood vessels, right? So ultimately cardiac muscle also will be getting relaxed, right? So that the pressure on the heart also will be less. So by that, these drugs are also affecting in congestive heart failure, right? Next, if you're telling about a RAS system, renin-angiotensin-aldosterone system, actually this is really it is a widely used mechanisms for antihypertensive drugs. Why? Because this RAS system actually working for low BP to normal BP. But how this RAS system will work in antihypertensive drug, I will explain it. Okay, so now RAS system, if you're telling about the full form of RAS system, is renin-angiotensin-aldosterone system. So here, how this RAS system will be working to our body. So the liver, from the liver, there will be secretion of angiotensinogen, one enzyme, and kidney, there will be secretion of renin. So this renin and angiotensinogen will combine together and it will convert to angiotensin 1. And then while this angiotensin 1 will be traveling throughout our body for the circulations, and once it will be reaching to the lungs for purification, there's one enzyme called angiotensin converting enzyme, which is already been sitting. So this angiotensin 1 will be converted to angiotensin 2, and this angiotensin 2 will be working as important vasoconstrictions, and it also will be working as in sodium reabsorption, increasing of sodium reabsorption, increasing of aldosterone effect, increasing of vasoconstriction, and increasing of sympathetic activity, or say increasing of sympathetic activity, correct? So ultimately the low BP will become normal. Now if this RAS system will be activating more and more in our body, then there will be a problem. So there will be an increasing of vasoconstriction, there will be an increasing of pressure on the wall of blood vessel, there will be increasing of normal BP to high BP, right? So now this particular kind of drugs, ACE inhibitors, what it will be going to do, this kind of drugs will be see, if I say about that, ACE inhibitors. So if I blocked this ACE, so ACE, if I give the drug of ACE inhibitor, captopril, ramipril, this kind of drug, so this will be directly blocking conversion of angiotensin 1 to angiotensin 2. So if there will be no conversion of angiotensin 1 to angiotensin 2, so ultimately it will be not working as a potent vasoconstrictions, right? So ultimately it will be not increasing the absorption of sodium, it will be not increasing the aldosterone effect, it will be not increasing the vasoconstriction, ultimately it will be not increasing sympathetic activity in CNS, so ultimately PP will be goes down. The same way, if I give renin antagonist, so ultimately there will be no conversion of angiotensinogen to angiotensin 1 by combining with the angiotensinogen and renin. So ultimately further steps will be not followed. So ultimately blood vessels will be getting relaxed, and then our BP will be goes down. Okay, so these ACE inhibitors, what are the pharmacokinetic action of these ACE inhibitors? The better oral bioavailability, T-half is only 2 hours, then ADR. So what are the ADR? You can be getting hypotension, so you may get because of excess of blockage of these conversions. So we may be getting hypotension. Hypotension means decreasing the BP. The patient may even suffer from the high BP to low BP. So acute renal failure, the acute kidney failure may be occur. So this kind of ADR may be getting. Then therapeutic uses of this ACE inhibitors is hypertension, obviously. Then coronary artery disease, already I have explained. Coronary renal failure, kidney failure, congestive heart failure, already explained. Left ventricular systolic dysfunctions. These are the things. Then angiotensin receptor blockers. In this, we can say that it will be relaxes the vascular smooth muscles and promotes salt and water excretion and reduces the plasma volume. As I already said that if we are giving this kind of drug, it will be relaxing our smooth muscles in the heart. So ultimately, it will be relaxing the smooth muscle in the heart, means the heart muscle will be getting relaxed and the pressure will be goes down. So ultimately, and also it will be working as an water excretion and reduce plasma volume. So ultimately, the pressure on the wall of blood vessel will be going down. So ultimately, the patient will be suffering from hypertension. Now the patient will become normal after giving this kind of drugs. So what is the pharmacokinetic section of this kind of drugs? Is high first pass metabolism, highly bound to plasma proteins, absorption is not affected by the food, and T-half is only 6 hours. And then the ADRs for this, risk of cough and angioedema, hypotension and hyperkalemia. So there will be chances of getting low BP, then hyperkalemia, the increasing of potassium level may be occur, then therapeutic uses of hypertension, cardiac failure, and diuretics. So the renin inhibitors, already explained. Renin inhibitors, what is renin inhibitors? Is nothing but whenever we just give this kind of drugs like Alice chirin and remichirin. So this will be directly inhibiting the renin, inhibiting the synthesis of renin or inhibiting the renin production. So ultimately the renin, if it is not productions will be not there, it will be not binding with the angiotensinogen and further conversion will be not there, and in this resulting decrease in the blood pressures. So these are the mechanism, renin inhibitor, if I say that. So if we block this, if I show you here this angiotensinogen, then there will be a renin, then angiotensin 1, then angiotensin 2. So this is the flow chart. Okay, so whenever we are giving any kind of renin inhibitors drug, so this angiotensinogen, which is already been secreted from the liver, it will be not binding with the renin, and then angiotensin 1 will be not activated, then SCE will be not activating to convert angiotensin 1 to 2, then ARBS, then aldosterone productions also will be goes down, output of sympathetic nervous system will decrease, then increase vasodilations, by that the blood vessel will getting relaxed, then retention of sodium and water will be decreased, then decrease the blood pressures. So pharmacokinetics is it is orally active, T half is about 24 hours, it is reduced plasma renin activity by 50 to 80%, it is metabolized by liver and excreted through the urine. So the ADR, so there may be a getting of diarrhea, cough, angioedema, hyperkalemia, and therapeutic uses, the heart attack, kidney failure may be getting it. Then beta adrenergic blockers, the alpha selective beta adrenergic blockers is parazosin, terazosin, doxazosin. The non-selective beta adrenergic blockers, it is phentolamine, phenoxybenzamine. And what is the mechanism actions about this beta adrenergic blockers? Let me explain in this flow chart. So beta adrenergic blockers, after giving this kind of beta adrenergic blockers drugs, so they will be binding with the beta adrenoreceptor blockers. They will be acting as the beta adrenoreceptor blockers. So it will be binding with the beta 1 adrenoreceptor on the heart, and it will be decreasing the activation of beta 1 adrenoreceptor on the heart, and ultimately if it is blocking that, so ultimately the heart muscle will be getting relaxed and cardiac output also will be going down. So by that the heart will not get extra load or extra pressure, so ultimately it will be decreasing in the blood pressure. So another way, decreasing in the activation of beta 1 adrenoreceptor on the kidney. Okay, it is affecting on kidney. So renin, it will be decreasing in the renin production, decreasing in the angiotensin 2 production, decreasing in the aldosterone ultimately, then decreasing the sodium and water retention, and ultimately blood volume decreases. So ultimately if this all kind of things will be going to happen one by one steps, so ultimately it will be decreasing in the blood pressures. So the pharmacokinetic actions of these beta blockers are orally active, and obviously if you are taking this kind of drugs in orally, so ultimately it will be metabolized, it has to be metabolized by the liver, and T half is 3 to 7 hours only. Then ADR is bradycardia, fatigue, insomnia, sexual dysfunction may occur. The patient may also suffer from the hypertension. The patient may suffer from the fatigue, means tiredness. So this kind of ADR may be getting after consumption of these beta adrenergic blockers. Now therapeutic uses of beta adrenergic blockers, it is nothing but myocardial infections, then angina pectoris, chronic heart failure, hypertension. So now every time I'm telling about the heart related things, the uses of these drugs in heart related things. Why? Because it is related to these things in hypertension. So whenever we are giving any kind of antihypertensive drugs, ultimately why we are giving? To decrease the load on the blood vessels, and blood vessels are present in everywhere, right? So if the blood vessels are present in everywhere, so if the heart muscle will be getting relaxed by giving a drug, so ultimately it also decrease the load of the heart. So ultimately it will be working on the heart related problems. So that's what this particular drugs are also working in the heart related problems. Then alpha adrenergic blockers, selective alpha adrenergic blockers is parazosin, terazosin, doxazosin. Non-selective alpha adrenergic blockers, phentolamine, phenoxybenzamines. So how it is working? Increasing the vasodilation and decreasing BP. Yes, ultimately if we increase the vasodilations in the blood vessels, ultimately the pressure will be decreased and ultimately BP will be decreased. What are the pharmacokinetics action? Let me check. Let us check what are the pharmacokinetic action of alpha adrenergic blockers. It is orally orally we can take, and the bioavailability, if you are taking oral route, it is 60%, high bound in plasma proteins and metabolized in liver and excreted through the urine, and T half is only 2 to 3 hours. Then alpha adrenergic blockers, if you are taking these alpha adrenergic blockers, it will be increasing the vasodilation, and it will be nasal congestion will be decreases, decrease ejaculations, decrease headache, it is helping in the tachycardia, postural hypotensions. So ultimately, due to decrease in the vasoconstrictions, ultimately BP will be getting relaxed. What are the therapeutic uses? Used in hypertension, obviously, cardiac congestive heart failure. It may be added to diuretics. Yes, if we are adding with the diuretics, ultimately water retention will be not there. It will be excretions mode in the water. So ultimately, it will be affecting as a for controlling the high BP to normal BP. So next it is alpha and beta adrenergic blockers. The example is levotalol and carbidopa. So if you are taking this alpha and beta adrenergic blockers, it will be blocking both alpha and beta receptor, and ultimately it will be, if it is both alpha and beta receptor, it will be blocked. So ultimately both systolic and diastolic pressure will be blocked. So ultimately it will be goes down, and there will, because of vasodilation, it will be goes down. So ultimately BP will be comes under control. So now is calcium channel blockers. The L type of calcium channel blockers, verapamil, diltiazem, then dihydroviridine, under that nifedipine, nicardipine, lecidipine. So what are the mechanism of actions for this? The intracellular concentration of calcium plays an important role in the maintaining the tone of smooth muscle and the contraction of the myocardium. So ultimately the thing is, if I just give one example of calcium channel blockers, and let me explain about this, how it is affecting in the how it will be working as an antihypertensive drugs. So as we know, calcium are required for contraction of the heart muscle. Ultimately myocardium is nothing but it's a heart muscle for maintaining the rhythmicity of the heart, and conducting cell and contractile cell are required a calcium and all other ion channels, sodium and potassium, to maintain it, to maintain the voltage, to properly contract the heart muscles. So if calcium enters muscle, if calcium will be entering more to the heart muscles, so ultimately heart rhythmicity will be increased, right? So ultimately heart will get a more load. So ultimately the pressure on the heart also will be more. So ultimately it also lead to a pressure on the kidney, right? So ultimately the pressure, blood pressure will be high. The systolic and diastolic also will be affected. So ultimately it will be, the pressure will be high. So if you are giving this calcium channel blockers in the condition of hypertension, so ultimately it will be relaxes, it will be inhibiting the calcium and influx to the cardiac muscles. It will be making limited. So ultimately the myocardium regions of the heart, it will be relaxed. So ultimately the blood vessel also will be getting relaxed. Ultimately vasodilation will occur to the heart. Ultimately BP will be goes down to the normal. So next is pharmacokinetic actions for calcium channel blockers. Is most of these agents have short half-lives, 3 to 8 hours only, and metabolized in liver, excreted in urine. Why it's metabolized in liver? Because we are taking oral route. And why it is excreting through urine? Because it is also been taken by the drugs has been taken by the orally. That's what it's metabolized in liver and excreted through urine. What are the ADR after taking this calcium channel blockers? So we may get a little bit of dizziness, we may get a little bit of headache after take consumption of this kind of drugs, and feeling a little bit of tired, and peripheral edema we may get some time for shorter period of time. And what are therapeutic uses? Hypertension, treatment of angina. What is angina? Angina is nothing but whenever you are getting a chest pain. Why? Because of if the heart is blocked. Heart is blocked due to the deposition of the fat, and heart is unable to receive enough amount of blood and enough amount of oxygen. So in this case, so ultimately heart, because of less amount of oxygen supply to the heart muscle unable to receive all kind of energies, and heart will be paining, chest pain will start. So that we can say it is angina. So if this kind of drugs, if you are giving calcium channel blockers, this also will be helping to working as an angina and arrhythmiasis. Next is potassium channel openers. So minoxidil dioxide. So this kind of what is the mechanism of action of this kind of drugs? Opening these channels in hyperpolarizes the smooth muscles, which closes voltage gated calcium channels and decrease intracellular calcium. And obviously, if this is happening, this leads to a relaxation and vasodilation of the muscles. Ultimately, the pressure will be relaxed and the hypertension will be going down to the normal BP. So this is the things in the flow chart. We can say the potassium channel openers, see open K ATP, then enhance potassium efflux, then membrane hyperpolarization, then decrease calcium entry, then reduce intracellular calcium, then smooth muscle will be going to be getting relaxed. So why? Because if calcium entry will be more, so ultimately the contractions will be more, so ultimately the pressure will be more, ultimately the patient will suffering from high BP. So now if you are giving this kind of potassium channel blocker, this calcium entry will be reduced, so ultimately reduce the intracellular calcium, then smooth muscle will be getting relaxed, and there will be a decreasing of the BP. So what is the ADR? What are the ADR for potassium channel openers? It's headache, flashing, reflex tachycardia, fluid and salt retentions. Then therapeutic uses: hypertension, smooth muscle relaxing activity, then vasodilator to treat angina. So vasodilators, hydralazine, minoxidil, sodium, nitroprusides. So how these vasodilators will be going to work? Hydralazine molecules combines with receptors in the endothelium of arterioles, then no release, relaxation of vascular smooth muscles, and fall in BP. See, why it is all time of relaxations? Because the heart muscles or the blood vessels, we can say the blood vessels will be constricted, right? So because of this constriction, the pressure was increases now. Because of pressure was increases. So pressure was increased on the wall of the blood vessels, right? So that's what, whenever we make it relax of the heart muscles, so make it relax to the blood vessels, so ultimately BP also will be going to be relaxed. So ADR is hypotension. The patient may be suffering from hypotension after taking of vasodilator medications. The salt and water retention may be there. Then why the salt and water retention will be there? Because the blood vessels were dilated now, so it will be getting more space. So there will be chances of retention of more water and salt. So ultimately, this one kind of ADR may be getting after taking a vasodilator drugs. Then headache we may get it. Then the therapeutic uses of vasodilators: heart failure. In the situation of heart failure, you may give vasodilators to control the pressures. Then angina and myocardial infarctions, ability to inhibit platelet aggregations. And the centrally acting sympatholytics, so it will block the sympathetic activity by binding to an activating alpha-adrenergic receptor. Why? Because how this will be working? Because already a heart is unable to pump. Already the pressure were increases in the blood vessels. Again, if sympathetic system will be activating more, ultimately again it will be getting more signal to the brain, and again it will be a more constrictions will occur, right? Again it will be more constriction will occur, and ultimately again the persons will be maybe suffering from hypertension. So there will be requirement of blocking of sympathetic activity. So by that the signal will not much reach to the brain, to more activations of this constriction of the blood vessels. So ultimately it will be getting relaxed, and hypertension maybe goes down to the normal. Now centrally acting sympatholytics, this reduces sympathetic outflow to heart, thereby decreasing cardiac output, yes, by decreasing the heart rate, yes, and contractility, and which causes the vasodilation, yes. So obviously it reduces the vascular resistance, which decreases an arterial pressure. So ultimately it decreases the blood pressures. So now what are the ADR for this? Bradycardia, not good for emergency conditions. So this kind of drugs we cannot give in emergency conditions, because so many of, if the patient may get accidentally, if the patient may get accident, and if you are giving this kind of drugs, this kind of drugs may be contraindicated. Why? Because this kind of drugs are blocking sympathetic nervous system totally. If we are blocking sympathetic nervous system totally, so the signal will not reach to the brain. Somewhere there also may be some reflex mechanism may be activated, and there may be chances of some different issues. So this kind of drugs has to be avoided or not to be suitable to give in emergency condition. And dryness of mouth, maybe getting then vertigo, bradycardia, dryness of mouth already have said na, so not good for emergency conditions. Therapeutic uses, hypertension obviously associated with the pregnancy, since it is safe we can give it for the pregnant women also. Then these are the references. So thank you everyone.